the authors have no financial interests. Cataract surgery in eyes with iridofundal coloboma is associated with greater risk of intraoperative complications like capsulohexis tear, posterior capsular rent, vitreous loss, and zonular dialysis. In this video, we share our insights into the challenges faced. The authors prefer to use iris hooks even in mid-dilated pupils and advanced cataracts. This helps save the hassle of small capsulohexis. Initiation of capsulohexis, away from the area of coloboma, and creation of an eccentric rhexis, smaller in the area of coloboma, are the mantras to avoid a primary rhexis tear. The surgeon needs to vigilantly look out for subtle signs of zonulopathy, such as distinctive capsule folds in this case. If suspecting zonulopathy, the authors prefer capsular hooks over capsular tension ring for stabilizing the bag prior to nucleus emulsification, as the insertion of hooks is much easier in these small, crowded eyes. We have recently described the novel rhexis stress rip sign, where we reported a series of secondary rhexis tears during surgery in coloboma cataracts. Here, the tear occurs in the coloboma area due to stress exerted on the capsulohexis margin by a blunt force from within during nucleus dialing in ECCE. Organ, from the outside during insertion of capsular hooks, or CTR. We presume this is due to the abnormally fragile nature of the lens capsule and the lack of zonules. Phaco-chop is our preferred nucleus emulsification technique. The bottle height is kept low to avoid infusion misdirection. Also, capsular hooks help to a certain extent in avoiding this hazard. Capsule tension ring is placed in cases with zonulopathy after complete cortex removal, and IOL is implanted in the bag. For iris repair, the authors prefer using a 9-0 Prolene suture attached to a long curved needle, which is passed ab externo through the cornea, coloboma margins, and out. The proximal suture end is externalized, followed by the distal suture loop. Fourth-row pupilloplasty technique is then used. When passing a straight needle ab interno through the corneal tunnel, sideways movement of the needle ensures that there is no entanglement to the corneal tissue. Maneuvering a bent straight needle is slightly more difficult. Inaccurate bending of the needle can cause additional iris damage. Small incision cataract surgery, although useful in these eyes, have their own set of challenges. Here, after nucleus delivery, rhexis rip sign is noted due to stress exerted on the rhexis edge while prolapsing the bulky nucleus. Also, there is posterior extension. To avoid this, we recommend combining a large eccentric rhexis and multi-quadrant gentle hydrodissection with bimanual technique of nucleus prolapse. In bimanual technique, a blunt cyclodialysis spatula is inserted under the nucleus, which acts as a fulcrum to support the zonules, while nucleus is being dialed out of the bag using Sinski. This technique is safe even in black cataracts. In microcornea and capsule calcification, intentional capsular cuts may be given to avoid rhexis rip and posterior extension. In severe microcornea, a long tunnel is mandatory to avoid decimet membrane detachment during nucleus delivery. Coming back to our case with rhexis rip and PCR, there was no vitreous disturbance, and single-site retro-iris fixation of rigid IOL was performed. A 9-0 Prolene suture attached to a long curved needle was passed ab externo through the cornea, mid-peripheral iris, and brought out. A suture loop from under the iris was retracted through the scleral tunnel and twirled around the leading haptic of a rigid 3-piece IOL multiple times. The loop was pulled close to the optic-haptic junction. The leading haptic was inserted into the sulcus, pulling the suture ends gently. The trailing haptic was then slid into sulcus. The distal suture loop was pulled out, and the externalized proximal suture end was passed through the loop 4 times and tied. The tilting of IOL confirmed fixation. This single-point iris fixation prevents post-operative IOL decentration. Iris haptic fixation technique is useful in rhexis rip with zonular weakness, when CTR cannot be implanted. It is safer in coloboma eyes with inherent risk of retinal detachment as there is less tissue handling. We have devised a modified haptic fixation technique, double fix for these cases. The multi-piece IOL is placed vertically with inferior haptic in the area of coloboma and rhexis rip. The procedure is same as in iris coloboma repair, but only to include the inferior haptic in the iris bite. Also, it is repeated at 2 points to ensure fixation to the congenitally defective iris.
Thank you, sir.
Hi Hridya, your presentation was very nice. I wanted to ask, what is your approach, if your coloboma is opposite the side of your incision? If it's on the size of your incision, it's easier on the side. If it's on the opposite side, what approach do you usually prefer?
I'd like to do the same way, ma'am, because making a rhexis smaller in the area of the coloboma is what I found that it's a little useful, and I don't think that makes much of a difference, ma'am.
And you have said like if there is a capsular rip, so how do you proceed further, because you cannot put a CTR then, no?
So that's what I showed in the video. I prefer to do an iris haptic fixation for these lenses because later on, otherwise if you don't fix the haptic, the lens might decenter and then the patient will have discomfort. So I prefer to do a haptic fixations.
So like in this post-surgery, have you noticed any inflammation in the cases or any case because of the iris manipulation?
Not really, sir, because...
A long-term uveitis or something like that?
Not really, sir, because usually in these cases, the rest of the area, the sulcus is usually intact. So you just need to do fixation of one haptic. There's no need to do both the sides. And I haven't noticed much post-op inflammation.
So not even decentration?
No, no decentration. And inflammation is, I don't find it excessive. Like maybe we might have to continue anti-inflammatory for another month or so. But as such, the patient has not developed any CME or anything post-operative.
You are putting a 3-piece lens and fixing it to the iris.
Yes, sir.
Why not put a retro-iris claw?
Retro-iris claw, I feel, needs more. When there is a lot of sulcus support remaining, why do we have to remove the bag and do a vitrectomy and do it for the patient, sir? Because in rhexis stress strip sign that I've noted for my cases, most of the patients do not have vitreous disturbance because it's because of the fragile anterior capsule and the lack of zonules that the rip happens and it goes posteriorly. Most of the cases do not have vitreous disturbance, so why do we have to pull out the bag and do a vitrectomy and do retro-iris fixation? So that was a thought, sir. Especially in these colobomatous eyes when they have chances of retinal detachment, I think retro-iris, haptic fixation will be a better choice.
Any questions from the audience for her? It's a very interesting video.
Thank you, sir.
Yeah.